morning. I just want to welcome, I'm Diana Farmer, the chair of the Department of Surgery, for people who don't know me. I just want to welcome many new colleagues to this morning's session, particularly since we have lots of new trainees in both of our departments. This is a joint meeting of the Department of Anesthesiology and Pain Medicine and the Department of Surgery. I also particularly want to extend a warm welcome to our plastic surgery colleagues back into the fold after a decade. Really glad to have you and appreciate the effort that was involved in changing the other educational programs in the Division of Plastics to make this happen. I'm sure that the surgery residents are all going to, at the end of this day, I hope we have all of our meetings combined with the anesthesia department because you have better breakfast in the morning. So we're going to have a high bar here. We'll have to talk about this later.
Okay. Fair enough.
But as everyone's getting settled, we have a big agenda this morning, and so I wanted to start by introducing Dr. Doug Kirk, who many of you may or may not know, and certainly for all our new colleagues, is the Chief Medical Officer for the hospital, and he's been responsible for putting together and helping shepherd this particular joint session. So I'll turn it over to you, Dr. Kirk.
Good morning. Well, it's a pleasure to introduce this interdisciplinary grand rounds between the Departments of Surgery and Anesthesiology on perioperative blood management. I go back 5 years when we developed the Choosing Wisely initiative for the hospital, and it was an effort to mimic the national initiative which was put forth by the ABIM to reduce utilization of unnecessary testing or therapies. We focused on imaging and lab utilization in those early years and had some early successes. In 2015, Laboratory Medicine developed the Transfusing Wisely group, the nickname that they created for themselves, and this group has really flourished. They've really done some amazing work focusing on utilizing blood appropriately for all of our patients. That work has now moved into the perioperative space, and I think you'll see today that they're doing some fantastic work. Early on, they really focused on policy revision and management to guide our therapies, changes in the EPIC system to tailor order sets to be appropriate and follow guidelines. They created dashboards, and they went on an educational campaign, much like what you're going to see today in perioperative blood utilization. These efforts have really paid off. We have seen a dramatic reduction, nearly half, reducing multi-unit transfusions throughout the hospital. And we've also seen a great improvement, about a third improvement in using a hemoglobin less than 7 to trigger transfusion. So tremendous amount of work that is paying off. Doctors Jurkovich, Dr. Applegate, Dr. Littlejohn have joined Sarah Barnhard and her team in this effort to address perioperative management. And I think these 4 speakers today will show you some fantastic work that they've put together. It's a rich, robust, packed agenda. I'll be surprised if we can get through all of it in an hour, but they'll make all the efforts to do so. They've asked me to ask you to hold your questions to the end so we can get through all the material, and then they promised to leave at least 10 minutes at the end of the session to answer your questions. So without further ado, I'll introduce Jim Littlejohn from Anesthesia to start us off and welcome you to this program. Thank you.
Thank you, Dr. Kirk. For those of you who don't know me, I'm Jim Littlejohn. I'm one of the anesthesiology attendings here at UC Davis and work in the SICU. It's my pleasure to stand up here and sort of introduce this topic. It's one that's near and dear to my heart. All towards the end of this work of patient blood management, PBM, which is a new term if you're not familiar with it. It's going to be one of those buzzwords like quality of care that's not going to go away. That's super duper important just because it actually has a profound effect on the health and recovery of our patients. It has a profound effect on managing a limited resource and also a profound effect on cost. There's very few things that actually, if we do it right, we can improve the quality of our patients' care, we can reduce the cost, and we can improve the availability of a life-saving product for those who need it. Because of that, we're asking you to sit here and wade through a lot of really important data and really important considerations. There are no easy answers here. The real answer, the real success that we will do at the end of this talk is really to engender some good critical thought and discussion every day with every patient that we co-manage together, both in the OR, preoperatively and postoperatively. If we do that, I guarantee you we will be successful in delivering the highest quality care, and as a part of that, even without trying, we will reduce blood transfusions. We're going to start by telling you the end, okay? So at the end of this talk, these are the three things we want to drive home, or at least sort of tease out and get people to really start talking about. We want you to start considering transfused red blood cells as not that good. In fact, some of the data and a lot of the considerations are showing that unless your patient is anemic and also dying, that a unit of transfused packed red blood cells is not the best thing for them. We're not quite sure what is yet, but a lot of the data, especially in these critically ill individuals, is really showing that red blood cells might not be as good as we thought. Next, towards this end, we all talk about transfusion thresholds. We have to talk about transfusion thresholds, and it's easy for us to focus on what we can measure, which is the number. And we started off with these thresholds and these numbers at the beginning of these discussions about a decade ago. What we're realizing is that we have to take that number and actually apply it to our clinical scenario, our patient. So we take the hematocrit and hemoglobin number, whatever that is, and we look at our patient. If we find evidence of symptomatic anemia, absolutely. You can make a good reason to transfuse them with a unit of red blood cells. And in fact, we should get better at documenting why. This will allow us to move beyond just the number, what that number is, and allow us to really, when we do transfuse them, allow us to study them and actually figure out if that rationale is correct or if it's not as correct as we may have assumed. Finally, in order to bring this home to UC Davis, as part of this work, when we started counting and learning how to count in our EMR, we had to really define the problem. And we initiated a survey last October 2017 to really actually try to answer a little bit more what our current transfusion practices are. And as it turns out, when we've counted the people who got red blood cells in that 6-month period around the survey, we've discovered that based on the very simple guidelines of transfusion as currently accepted, we're transfusing too many red blood cells to the patients in our elective ORs. Ironically, this may not be a firm conclusion, but the use of our point-of-care hemoglobin analyzers in the OR may actually lead to overtransfusion. We're not sure yet, but you just have to take the number that you're measuring and apply it to your scenario. So what I can tell you is little is actually known about our, as a group, our perioperative red blood cell transfusion practices. So we initiated a survey. It was 127 respondents, which is roughly 35% of the folks we surveyed. All comers, all order writing members of both departments of surgery and anesthesia. We extended it to the Department of OBGYN, anybody who holds time in the main ORs we surveyed. We roughly got about 35% response. It was a very heterogeneous response rate between residents, nurse practitioners, and attendings in both departments. So this was actually a representative sample size. There was a member of every surgical service that did reply. With that said, it's not a complete survey of all of the departments, but for purposes of statistics to inform what we do, I think it's a great sample size. We conducted this October 2017, and at that time, these were the currently accepted, roughly just very simplified transfusion thresholds as accepted by the AABB, American Thoracic Society, and any society who actually makes recommendations about when to transfuse a normal patient, quote unquote. So what we think we do, how we responded on the survey. So the question was asked, what is the acceptable packed red blood cell transfusion threshold, the hemoglobin or hematocrit, for hemodynamically normal, asymptomatic patients without cardiovascular disease in your patient population? And in fact, we answered correctly, I would say. We answered, the majority of us in our perioperative realm accept 7 as the acceptable threshold. And there's always going to be a group of people who have a higher expectation for their patients, who believe their patients are sicker, or for whatever reason don't match that threshold. This is interesting information, but I would say this is acceptable. If the majority of us, roughly 80% of us, accept those thresholds, or maybe even below those thresholds, that's fantastic. We move on to take the prototypical elective surgery or healthy patient with coexisting cardiovascular disease. These are ways we've all learned the currently acceptable transfusion thresholds, and we re-ask the question, And then we moved the limits up. We queried less than 8, 8, and greater than 8. You notice that, again, I would say the majority of us still sit within that 8. The acceptable threshold is probably 8 to 9 at the moment, depending on how you define cardiovascular disease and depending on how you define your patient. This is fairly good, but we realize that we do tend to transfuse red blood cells to people with coexisting cardiac disease, whatever that means and for whatever reason. This will be interesting when the data is presented about cardiac surgery patients specifically, when we consider whether those red blood cells are good. So that's what we think we do. So over the last 2 years, we've been getting really good at refining data, mining data, and actually working to put constructive data about our current practices and make it available for us as practitioners to know exactly what we do. You would be surprised, it's actually incredibly difficult to get good data out of this. It's taken us about 1.5 years. So this is the product. I'm going to show you 2 important slides just to drive home what we actually do. And of course, there's going to be a lot of questions, and I hope to spark a lot of questions because what we're going to present to you later is a website that actually allows us at UC Davis to look at our own practices within our own surgical subdivisions, the transfusion dashboard, which will be presented to you later. But in the 8 months that we looked at the data, we did over 17,000 surgeries, 13,000 of which were elective. Of those elective cases, we transfused 413 patients with red blood cells. Of those 413 patients, they received a total of 1,065 units of red blood. So in a half a year, we gave 1,065 units of red blood to our elective surgical patients. That's great. We looked at the hemoglobins, both pre and post, and what I want you to focus on in this slide is post-op. So if we accepted that our acceptable transfusion threshold in a simplified patient, in a healthy elective patient, would be 7. And we accept the current way of thinking when you give a unit of red blood cell to a typical 70 kilogram patient, you raise the hemoglobin level by 1 gram per deciliter, or the hematocrit by 3%. So if we adhered to what we think that we do, and we transfuse patients at 7, then really they should come out at highest 8, or roughly around 8. And what I want you to focus on here is the post-procedure hemoglobin value. And there's almost 40 to 50% of our patients on any given month, and we broke it down month by month, are coming out not with a hemoglobin of 8, but actually a hemoglobin above 10. That's shocking, and we want to figure out why. So we started asking questions, okay, well, it's very difficult to actually get the rationale of the practitioners. We do have the EMR, we do have the anesthesia records, we've got surgical notes. But a lot of the rationale for transfusion of red blood cells, either intra-op or post-op, is not documented, something we're working on and we're asking everybody in this room to work on. But we started by looking at, well, are our patients starting out anemic? And some of them are. Some of them are starting out anemic. The green line is hemoglobins below 8. The gray line is hemoglobin between 8 and 9. And however, some are actually starting out just fine, above 10. And in fact, on some months, we're actually pushing the bar. We're pushing more patients after surgery higher than 10. You could make the argument the patients who come out in this red line here did not need the red blood cells in the first place. And that's what we want to get to the bottom of. There's the question about whether or not the point of care, the epochs, are leading to this. Is it making the problem better? If we use point of care hemoglobin measurement in the OR, can we reduce transfusions? That's what I actually would have thought. But when we look at all 413 patients, that includes measurements with epoch. We get these post-op hemoglobin values. If you take the epochs out and just focus on the laboratory CBCs, the number actually goes down a little bit, but I would say the trend is the same. The bottom line is too many of our patients are coming out of the OR, too many of our elective surgery patients who are coming in from home, who are healthy, who are probably going home very soon within a couple of days, are coming out way over transfused. We need to figure out why. Before I finish, I want to talk briefly about when we transfuse. How many units of red cells should we transfuse? So getting back to our survey, we talked about a prototypical patient, a stable, asymptomatic, non-bleeding patient. I need to emphasize non-bleeding, okay? So in a hemorrhaging patient, that's a different story. However, in an elective case, the tourniquet on a limb or something where we can control the bleeding, you can say that that's a non-bleeding patient. How many units of red cells should you transfuse to somebody whose hemoglobin is 6 or hematocrit is 18? So we chose 6 as one well below the trigger to get people to say we're going to transfuse. Ironically, some people were very strong in saying, you know what, they're not actually showing, you're not describing to me any signs of symptomatic anemia, I still would not transfuse. And that's fantastic to be honest. They want more information. A lot of us would just transfuse 1 unit, but there's roughly 15% of us who at that point would transfuse 2 units of red cells to that patient. If they're non-bleeding, we actually have to be very careful about expanding somebody's vasculature space by that much that quickly to somebody who's not bleeding. You can cause a lot of circulatory overload that we'll talk about in a little bit. And the bottom line is they probably just don't need that many red cells, so we're creating more harm than good. When we kick it up a notch, when we try to push it and try to figure out why we're transfusing those cells, we create a prototypical unstable patient, an unstable anemic patient who's also not bleeding. So now at least everybody will give a unit of red cells, but you find more people within the departments of surgery and anesthesia are more prone to give 2 units of red cells to that unstable anemic patient, even though they're not bleeding, thinking that these red cells will actually help them become stable again, which just isn't true. A lot of the literature says that in fact it's these critically ill patients who have worse outcomes the more red blood cells you give them. So yes, they're anemic. You definitely can make the argument they should get 1 unit of red cells, but whether they should get 2 units of red cells is an interesting matter of discussion. And hopefully we leave here discussing why we feel that we should give these unstable anemic patients more blood. Some patients may need the blood, some patients may not, but I think less than you think will need it. And there's no clear trend. Residents and attendings alike, NPs, and everybody who answered, the trend is spread out. There's no one driver of all of these trends, which is why we're presenting to everybody. I looked at my numbers. I did the same thing, unfortunately, and I'm up here talking to you about it. This trend is perfectly split between anesthesia and surgery, attendings and residents. So we don't wake up in the morning coming to work wanting to overtransfuse our patients. I think we all understand the science. We all understand this, and somehow we're still overtransfusing our patients. So at the end of my section, I want you guys to now hopefully get closer to accepting the fact that although we believe we're transfusing at acceptable thresholds, unfortunately, we're not hitting the mark. We need to look critically at what we're doing. Interestingly enough, one of the things we figured out is for our perioperative patients, we're not really good at checking their pre-hemoglobin values anyway. We found a lot of patients who got blood who had no pre-existing hemoglobin values. The bottom line is we do believe we're transfusing too many packed red blood cells to our elective surgery patients. And the reason why this matters even more is when you think about our urgent and emergent cases, the odds of us changing our practice for the urgent and emergent cases are 0. The elective cases are the healthiest in our mind and the stablest in our mind, which means when we see an urgent or emergent case coming in and they're unstable, if you think back to my slide 2 slides ago, right, the unstable anemic patient, we're prone to give them more blood without pre-checking. So this is just the tip of the iceberg. We can only really look and create good data for our elective surgery patients, but if that's our trend here, think about what we actually do for the urgent emergent cases. So when we do transfuse a unit of red blood cells to a non-bleeding patient, think about actually just giving a unit and rechecking the CBC, allowing their vasculature time to deal with the volume you just gave them, and actually see if they need another unit. So with that, I'm going to hand off to Dr. Barnhard, who's going to get in. So that's what we do here. Now we're going to get into the data, the current data about red blood cells, and move on and tell you why we think we shouldn't be doing it.
Thank you, Dr. Littlejohn. Good morning. My name is Dr. Sarah Barnhard. I'm the Associate Director of Transfusion Services here at UC Davis Medical Center, and I'm also the Chair of the Transfusing Wisely Quality and Safety Committee. This morning, very briefly, I'm just going to run down a few risks associated with transfusions and then hand it off to the other speakers for the morning. The main question is, are blood transfusions overall bad or good? And if we look at it from the perspective of the patient, some patients who receive transfusions, it's life-saving. And for some patients, they actually die as a result of their transfusions. And so really what we need to think about is what is our innate heuristic technique in practicing medicine? For everything else that we do, we try to minimize the risk and we maximize the good. The way that we minimize risk is by adding layers of safety mechanisms for our patients. And the way that we maximize the good is by choosing the right patients who should receive our intervention. In order for this model to work appropriately, however, we really have to have a strong understanding of the risks and of the benefits. And in transfusion therapy, unfortunately, some of the transfusion adverse events are quantifiable, but some of them are not. And the benefit that is proposed from transfusion therapy is even more nebulous, so it's an extremely challenging area of medicine to practice. This case of a transfusion reaction that occurred last year here at UC Davis was a bit sobering to me. This was a 63-year-old female who received an endovascular thrombectomy at an outside hospital. She was admitted for syncope and an expanding right groin hematoma. The massive transfusion protocol was initiated in her case because her blood pressure was unstable, although she was responding somewhat to Levophed and to volume that was given to her. Upon her resuscitation with blood products, she actually had an anaphylactic event. She had upper airway distress, she went into vascular collapse and respiratory failure. She was taken to the operating room for a pseudoaneurysm repair, and this case best fits a transfusion-associated anaphylaxis. This case is extremely sobering to me because I still think about sitting with the patient even now and asking her, would you rather have an anaphylactic event or an uncontrolled massive hemorrhage? She needed the blood. And I think that it's important for us to realize that if we can find the correct patients to carry the burden of this risk, that we can maximize the amount of good that comes out of the transfusions that we give. This is a more positive graphic that shows that some of the efforts in the transfusion committee to minimize risk have actually worked over the years. This is the trend of HBV, HIV, and HCV associated transfusion transmission over time. Just as an example, the HIV is the solid line. Starting in 1983, when the risk was around 1 in 100 transfusions, with the advent of new donor screening and additional donor questionnaires, that transfusion transmission rate has decreased to about 1 in 2 million. And I really wish that all of the transfusion risk mitigation strategies could look like this graph, but unfortunately they do not. Here at UC Davis, here are our statistics. In the calendar year of 2017, we transfused 6,516 patients. A total of 20,000, almost 21,000 red blood cell units, around 7,500 platelets, and about 5,300 plasma units were transfused at that time. We had 165 reported verified transfusion reactions and around 22 severe or life-threatening events associated with transfusions. I emphasize reported because there's many details in the literature that show that we're capturing around a third of the actual transfusion reactions by relying on manual reporting mechanisms. Hopefully in the future we'll be able to have some more sophisticated methods to be able to capture these transfusion adverse events, but for now it's manual reporting. These are some other sort of sobering statistics from the FDA. Their Center for Biologics Evaluation and Research, they require hospital reporting of any transfusion adverse events that lead to mortality. And then they accrue these statistics and they publish them. From 2012 to 2016, 186 patients in the United States died because they received a transfusion. If they transfuse around 5 million patients annually, that would be about 9 deaths per million patients transfused. So the question is this risk a lot? Is it acceptable? Is it unacceptable? And I would argue this is even more evidence that we just need to figure out which patients are the appropriate ones to give transfusion to and minimize the inappropriate transfusions as much as possible. The interesting thing is that the highest mortality rate that we see for transfusion adverse events are actually circulatory overload, otherwise known as TACO and trolley. This graph was published in a 2012 red blood cell transfusion guideline from the AABB. It's a logarithmic scale. On your far right is a risk of 1 in 1, and on the far left is 1 in 100 million. On the bottom, the open bars are adverse life events per person per year in the United States, risk of mortality. And then in the shaded bars are the risks of having a transfusion adverse event. And so TACO and trolley are somewhere around the risk of a death from a medical error. Those are comparable. The transfusion transmission rate of HIV and HCV is comparable to airplane fatalities and lightning fatalities. And the risk of sepsis due to a transfusion is approximately the same as a firearm homicide. So this normalizes some of the adverse events that we see in transfusions. What about unknown risks? There have been many epidemiologic surveys that have shown some really fascinating sort of statistics. In this multivariate analysis performed in 146 Western European ICUs, they found an estimated risk of dying at 1.4 times the risk if the patients were given a transfusion versus not. In this study, they speculate that 5.6% of the patients died because they had received a transfusion for unknown reasons. There's a nebulous entity that currently is being investigated in the transfusion community called transfusion-related immune modulation. We know that based on studies in trauma patients, burns, cardiac surgery, acute coronary syndrome, and pediatric critically ill patients, that these have all suggested increased mortality rates associated with transfusions. There is a dose-related response with an increased risk of death, increased risk of organ dysfunction, increased risk of infection, increased risk of length of critical care stay, and increased length of hospital stay. And then for any transfusions, there's an increased rate of cancer recurrence in these patients, and there's an increased rate of VTEs in emergency general surgery. So to me, the noise in the literature is extremely convincing that the risks are even higher than we can actually quantify for transfusions. We really need new and ongoing prospective randomized trials to tease out what exactly is occurring related to transfusions. And I believe that every transfusion actually causes harm to our patients. Some harm is severe, some is mild, and some of it is unknown. We can add layers of safety to minimize the known mechanisms of harm, and we can investigate the unknown mechanisms of harm. But I feel very challenged in my clinical practice to be sure to choose the right patients to maximize the benefit of transfusion therapy. And so I challenge all of you to think whether or not your practice scale is tipped toward the benefit and to transfuse the patient and not a number. So now I'll hand it over to our other speakers, Dr. Jurkovich and Dr. Applegate. And I just want to say that I'm extremely grateful because their support in this initiative is vital to our work. So, Dr. Jurkovich.
What a great crowd. Thank you all for being here. Save any food back there, or is it all gone? Greg? All gone. Okay, good. It's nice to have these two groups together. I'm going to talk a little bit about, let's see if I can make these move forward here. Yeah. Just briefly, we each have a small time here, but just a little historical perspective on why we give blood transfusions. A little brief talk, just a brief synopsis on how we respond to anemia physiologically from our body. And then you heard Sarah talk about this a little bit, but I want to emphasize the immune suppressive effects of blood transfusions. And then there are 3 critical studies that you should know about that advocate for that transfusion trigger being 7 and not any higher. And they all carry the catchy names of the TRACK, the TRIC, and the CRIT study. And those probably are the 3 ones that sort of bring this to the forefront. Do you know this? Blood transfusions were first used to cure mental illness. Sarah would argue that's still what we're trying to do when we give all these transfusions, is curing mental illness in our patients. I think you all know that the first successful human blood transfusion was in a postpartum OB/GYN hemorrhage patient, and James Blundell gets credit for being the first transfusion. The 19th century saw us explore physiology of the patient and the body and the human anatomy, and with that came the understanding of what a transfusion does, what blood loss does, how we respond to anemia. But the 20th century, as that emblem of Churchill and the Battle of Britain in 1944 emphasized, the development of world wars, the understanding of blood grouping, blood typing, the more safe transfusions made transfusions much more widely adopted. First blood bank, in fact, was in the United States and was at Cook County Hospital in 1937. I think most of you have heard this rule, the 10-30 rule, that should be the normal transfusion, 10 of hemoglobin, 30 of hematocrit. Well, that's based on an article in SGNO, now the journal called JACS. It was written by an anesthesiologist, and it was about how you should manage critical cases. And the statement of they should all be transfused to hemoglobin of 10 and hematocrit of 30 stuck from that article forward, and that's the basis of that rule. We transfuse about 1 blood unit every 25 seconds in the United States, and more than 50% of our patients in the ICU receive blood, and that's actually a really high use of blood transfusions is in both the ICU and in the operating room, as emphasized by this slide. Now, transfusion practices, as Sarah mentioned, started to become scrutinized when the risk of transmission of infectious species became widely known, and that the incidence of adverse reactions, as you heard, is probably more higher than you thought about. But the issue of the immune suppression issue really catches my attention. Before I get to that, let me just mention this slide. If you look at the hemoglobin falling from 14 down to 4, you can see that the cardiac index goes up. So that's physiology of the 19th century. As we bleed, and as our hemoglobin falls, our cardiac output goes up, trying to deliver oxygen to the periphery. But the other side shows that we are really good at that as a human species. and the lactate does not go up. We adapt. We adapt to a lower hemoglobin. We adapt to a lower hematocrit. We slightly increase our cardiac output, and there's no adverse effect in terms of lactate elevation during that time period. So our ability to adapt is really good. And on the other hand, if we try to over-transfuse and push our cardiac output by giving a lot of blood, that's harmful to the patient. As this widely known ICU-based study shows that if you try to maximize delivery of oxygen and try to push oxygen delivery too high, you have worse outcomes and more deaths. So that's the physiology of it. Now let me talk a little bit about immunosuppression. It began with the transplant surgeons. They're the guys. They always sit sort of here, right there. So they're still there. They jump to their seats early. They know this. Transplant literature, if you give a lot of blood, that's great because you immunosuppress the patients and they keep their transplants longer. First recognized in 1973 that the more blood transfusions you gave to transplant patients, the more they survived the organ that was transplanted, the more often that surprised. That was the first suggestion that transplanting blood, essentially blood transfusions of blood transplant, that transfusing blood immunosuppressed you and kept your transfused organs longer. Ron Nichols is a surgeon from New Orleans at the time. You all know the Nichols ball prep. Those of you in surgery, this is where it came from. Ron Nichols did a lot of studies on infections in trauma patients. And he interestingly found that the risk of infection after penetrating trauma was dependent upon the age of the patient. The older you are, the more you're likely to get infection. Whether you got a colostomy or not, in other words, whether the colon was injured or not, the total number of organs you were injured, and how much blood you received. It was not related to whether you were in shock or not. So somehow the number of blood units you received increased the number of infections. Argwal went on to show that it didn't matter what your injury severity score was, whether it was a low 1 to 10 or high greater than 25, the more units of blood you got, the higher was your risk of getting infection. And that shows the same with penetrating and with blood. In orthopedic patients, hip fractures, those of you who were in the audience last week for M&M will recognize this scenario. In orthopedic patients, the more units of blood you're transfused, the more likely you're to get an infection. Hence, orthopedic surgeons do anything they can, including transfusing TXA to increase coagulation and resulting possibly in an unwarranted thrombosis and stroke to decrease the number of transfusions. So there's that balance again that Sarah was so nicely talking about. What is the right risk here? Stop all transfusions, including giving a product that will cause a hypercoagulability in order to reduce this, or allow some transfusions. Where do you sit? But the cardiac literature was rarely where this took hold. 2001, the number of transfusion units you got increased the percent of cardiac deaths across the way. That was the first recognition of it. 2002, this article came out. Patients with no transfusion had a survival rate that was truly 15% higher than those who got any transfusion in cardiac surgery. So you'll see the meticulousness of cardiac surgeons in preventing the use of any blood transfusion, and this is why. And it's dose dependent. No unit, 1 unit, 2 unit, 3 unit, 4 units of blood transfused. The more blood you transfuse in a cardiac surgery coronary artery bypass patients, the lower your survival. It goes from 85% down to 40%, right? Significant. And in this study, the TRIC study, this is the first of the 3 studies I'm going to mention. The TRIC study, a multi-center randomized controlled trial, the TRACK study showed that the transfusion requirements after cardiac surgery, a randomized controlled trial, you can see on the yellow bar, those that got greater than 6 units of blood, their probability of mortality was 18-fold higher than if you got no transfusions. So clearly there's something wrong with giving a lot of blood. What followed then was this TRIC study, a multi-center randomized controlled clinical trial of transfusion in the ICU, published in New England Journal of Medicine, so it got a lot of press, and it described the risks of anemia or the benefits of transfusion in critically ill patients. And they used a trigger. They at that time, notice this was 1999, the restricted transfusion was considered somewhere between 7 and 9, and a liberal transfusion was above that. So that's even a little bit higher than we're considering now. 22 centers throughout Canada. It was an entirely Canadian study. I think it had some exclusion criteria. They had to be euvolemic when they were admitted to it. And of course, you can't randomize patients to doing this. And so they had a technique that used the Apache score, measurement of their injury severity. And then they randomized based on a high or low Apache score to either get blood or not getting blood. Now, that was their transfusion strategy. They started off with 6,500 patients. They ended up with 838 consents. And I want to call your attention. I don't know if we can get this to work or not, does it? This box right here, this is part of the problem with the study. 1,200 patients refused to participate in the study, half because the patients refused and half because physicians refused. So this gets essentially at that culture of not wanting to risk, if you will, or not wanting to be part of this issue of thinking that blood is really good, that we're innate with that culture, and not wanting to even give this a try. So because of that, this study was stopped early because of the failure to enroll enough patients, but nonetheless, they had enough data to do an analysis. Now just focus on the chart on your right over there. Mortality, restrictive policy, 18%. Liberal policy giving blood, 23%. Mortality throughout the hospital day, 22% versus 18%. Mortality in the ICU, way lower. 60-day mortality, way lower. And in fact, these are the graphs, the Kaplan-Meier curves, that whether you look at all patients on the right, Apache patients with low Apache scores on the upper left, and patients younger than 55, the restrictive policy, carefully matched patients, they all look the same. Restrictive policy all resulted in better survival in that ICU. This is really the study that's driven ICU care in that part, and here's the summation of it, particularly in those younger than 55, and particularly in those with an Apache score less than 20. Not only that, if you look at the number of transfused, this is really dramatic. In the restrictive strategy, people got an average of 2.5 units of blood. In the liberal strategy, they got an average of 5 to 6 units of blood. So a 50% decrease in the number of units transfused overall in that restrictive policy. I went through those conclusions as well. The last study I'll mention is this CRIT trial, published in Critical Care Medicine. Not much more contemporary, but a little bit. Is from the early 2000s. 284 ICUs, 5,000 patients. You heard it mentioned a little bit already. And here's the overall result of this. Again, the Kaplan-Meier curves. Those that were transfused, their mortality was significantly higher than those that were not transfused in the carefully controlled matched patient sample. So two big studies from the ICU, one from cardiac literature, the TRIC, the TRAC, and the CRIT study, all reaching the conclusion that there's an adverse effect for giving these transfusions. This has been summarized by this study that looked at all the randomized and controlled trials that have existed on this to date. There have been 12 of them, 5 in surgical patients, 3 in trauma, 2 in the ICU, 1 in a sickle cell disease, and 1 in GI bleeding. And the restrictive policy is being coded at between 7 and 8 at the current time. And no matter what, in the very least, you give a lot less blood if you use the restrictive policy, and there are no worse effects in the restrictive policy, and a lot of suggestion that it's beneficial to be in the restrictive policy overall. So that's the data behind this. We're going to conclude with Dr. Applegate having the last word until the audience takes over. Rich.
Good morning, all. Thanks for being here. If there's one thing that we can get you to take home today, it would be this. Dr. Jurkovich pointed out that it was an anesthesiologist's fault that we all have ingrained in our brain the 1030 rule. And some of you are aware, there's an online site, you can go look it up. There are some proposed ICD-10 codes that will get you surgeons reimbursement, extra RVUs for blaming the anesthesiologist. If you code it correctly, that's out there, you can find that. If there's one thing we can get you to remember, I hope it's this: treat the patient, not the number. Treat the patient, not the number. We need to change to that mentality. We need to be sure that we're doing this transplant of foreign tissue. Sarah skimmed over some of that. There actually is some pretty scary data out there about what happens to your recipients of that transplant. Make sure you have a reason. From a place that did a lot of neonatal heart transplants, it was great. It was life-saving. The kids survived. And then they came back with weird lymphoproliferative disorders that required chemotherapy. They developed post-transplant coronary artery disease and had the second and the third and the fourth transplant. These things are not without consequences. So treat the patient. But who's the patient? Does it mean that any time you transfuse, you should always be in that range, 6 to 8? Every patient needs the same thing. Is it always bad practice if you overshoot? Well, let me ask you this. Multiple trauma patient, he's in the ED, hypotensive, low pressures, fluorescent pulses, belly is growing, fast scan is positive, hemoglobin's 13.5. I don't need to transfuse this person, right? Would you order the transfusion protocol? Would you send the sample to the lab and hope that the stat process works and you get it back in 20 or 30 minutes and then send it to the blood bank for the 20, 30, 45-minute turnaround time? Or would you transfuse? Of course, you can bleed to death with a normal hemoglobin. If I transect your aorta, you can be dead with the same hemoglobin in that last drop as in the first drop. So treat the patient. And there is conflicting evidence. We have presented a very strong argument that more blood is bad blood. And in fact, maybe even that any blood is bad blood. But there is a little conflicting evidence. It is, in studies like this one in 2017, you'll see, Tran and others looked at this. If you exclude, why do patients get transfused? Because they're bleeding. So if you say, okay, wait a minute, patients who need 6 units of blood after cardiac surgery, that's not normal. Something's wrong there. So if you look at others, don't look at those. Unadjusted, yeah, it still looks worse. If you adjust for the things that you knew, bad ventilation, new MI, inotropes, or balloon support, well, then it's not really different. But if you adjust for the things we all know make the patients worse, well, then maybe it's a little worse. So there is a little bit of conflicting signal. I like signal, not noise, signal to noise ratio. There are some contrarian articles that say, well, wait. This is a Cochrane review from 2016. Absolutely. Restrictive therapy, less transfusion. That's good, we know that. And no evidence that it's worse. So if you just want to save money, and we all do, transfuse less. It's not hurting the patient, apparently. But the Cochrane group said, yeah, we really don't know if there are subgroups. And I think that the tip of the iceberg that Dr. Littlejohn mentioned is we don't really know who's under the surface because we don't document our transfusion decision making. We see that you gave it, we have no idea why. The only way we can hope to identify subgroups is to know what you were thinking when you gave or withheld that transfusion. It's the only way we can drill down and find out, are there subgroups that will do better or worse? And I think both are true. So this is an interesting meta-analysis published in 2015. If you look at it again, less mortality in some patients who get a liberal transfusion strategy. Ooh, that's off topic. That's against policy. We're not doing that. But who are they? Well, this is a better study looking at 2016. It's the people that we always get talked to about. Where the 1030 came from was physiology. So if you got bad delivery, maybe you need that rheology. Maybe that's better for you. Sick patients with bad cardiovascular disease undergoing major surgery, particularly cardiovascular surgery, might do better with a slightly higher hemoglobin. And I don't know what that number is. I don't know if that's 8, 8.5. I don't think it's 10, but I can't prove that yet. Orthopedic surgeons, some, yeah, they like to avoid transfusion, but it's not unusual that they say, but this one is my frail patient who needs that hemoglobin of 10 or 11. Or as we've seen in the day, we had patients transfused to over 14 here at UC Davis with no explanation of why that was done. These were not emergency. These were elective. No explanation for that. Certainly, if you look at that data, notice that it does overlap 1. So this is a very soft call. It looks like it might be better to not be quite so stingy if they have bad cardiovascular disease and are undergoing big surgery. If they're frail and having orthosurgery, inadequate oxygen delivery events, MI, stroke, death, organ failure, your sick, frail ortho patients might need a little bit higher oxygen carrying capacity. Again, this touches 1, so don't be saying this is strong evidence-based. This is a hint. This is a signal in literature that there might be subgroups. ICU, no different. Sick, healthy, well, you're not healthy if you're in the ICU. Sick, old, young, ICU, no difference. All right. The composite events, if you just add everything, this is a way to sort of make your study look stronger because you're counting things twice. About the same. Restrictive may be worse. But let's look at the other side. Does everybody have to be transfused just because their hemoglobin hit the trigger? Please say no. Please tell me no. We have taken care of lots of patients across the surgical practices. The lowest one I personally got through got down to about 2.5, 3. Hemoglobin, not hematocrit. Didn't get to the one who got to a hematocrit of 3 did not survive. But you can get people through. They feel terrible. They hang around the hospital longer. They don't heal as fast, and they certainly don't want to play soccer the day they're discharged, but they survive. Better evidence when you look at the cardiac surgery, natural experience. A lot of patients refuse transfusion. It's a limitation of treatment, and they do fine if you're careful and take good care of them otherwise. It may actually be worse. The number itself may not be as important as the degree of change. So if you look at the literature, it appears, this is just, if you look, mortality really doesn't fall until you get way down below 6. So even at 6, if they're stable, you don't have to rush. You can think it through. You can look for what's going on. The rest of the clinical scenario, are they about to open the iliac vein? Well, that might be a good time to think about it. Are they on the skin closure? Let's see if it's hemodilution. Let's see if we overcalled it. It happens. There are analytical errors. There are pre-analytical errors. Measuring hemoglobin can be confused. This is the cardiac. If you look here, this is that comparison. So it may be worse to go from 15.5 to 8 hemoglobin than to go from 10 to 6. Well, we wouldn't transfuse at 8, but that degree of drop implies that a lot of bad stuff happened to your patient. That outcome may be worse, and they may, I don't know yet, need a little bit more. So please, personalize your treatment approach. Treat the patient, not the number. This is precision transfusion medicine without the omics. You just have to think about what you're doing. I do think there are a few patients. It's not a majority, it's a tiny subset, but I think there is a subset, the signal is there, that might need to be a little different from what we're talking about, but we don't know who they are. I do not know how to risk stratify them preoperatively yet because I don't know what you're thinking when you transfuse. So if you're going to do it, document it so that we can look later and say, okay, that makes sense. Let's look to see if we can get more patients like that one and see what's really going on so we can develop a prospective trial to show, yes, that group really does need it, or no, it happened to just be a bad day for you. I don't know that answer yet, and we cannot know if you don't tell us what you're thinking. When you have time, please be sure that you check. So, our summary before panel, transfused blood is not good just because it exists. Giving it is not a good thing just because you know how. It's in the bank. Let's save it. We don't have to spend it. Unless your patient's anemic and dying, obviously. Treat the patient, not the number. I think we've said that a lot. We're going to keep saying it. Look for symptomatic anemia and treat the patient. Document what you said. And we're giving too much blood to our elective patients. It's hard to explain why a patient gets transfused from 12 to 14 in an elective surgery. I can't explain that. I have no way to explain that. There are a lot of things that we can talk about point of care, the analytical error. There are wide ranges of agreement. Limits of agreement are awful for some of these devices. So don't treat the number. And I think we're ready for panel. We're going to just kind of stand and yell. So everybody come on up. Good. We left 12 minutes. That was our goal. Dr. Harmon.
So first of all, great conversation. Lots of great data. Lots of evidence-based stuff to talk about that really was outstanding. I had a couple of questions. The first one was for you, John. I'll avoid the question about why are you leaving, because we don't have that, just for the record. But secondly, when you presented our data, you must have an idea of the distribution of cases where transfusion was occurring the most. I think that would be useful, particularly to this audience.
Yes, it's an excellent question, and one that definitely needs to be asked. The reason we looked at 8 months as opposed to just 1 month is, and it wasn't presented here, but actually it's almost like we expected that question. The distribution followed no pattern, or no discernible patterns that we could readily identify in that 8-month period. With that said, we do accept the fact that there definitely will be and are patterns, we're just not seeing it. So as we refine this data, we rolled our methodologies into how we populate our UC Davis dashboard. One of the, obviously, because I care about transfusions, one of the more important dashboards that's available, will be available to everybody soon, I think, is our transfusion dashboard, which allows you to actually do your own analysis on any given month. If we think, yeah, is June better than July? Is it a training and educational issue? Is it GI surgery versus ACS? Is it cardiothoracic? Is there a difference between pediatric cardiothoracic and adult cardiothoracic? This will allow you to look at your own practice and look at us in general. So as we've been doing this work, we've been working on populating this dashboard with refinable and queryable indices that each one of us can go and actually answer those questions for ourselves, as the Transfusion Wisely group also tries to delve deeper and ask those questions. So there probably are, we just don't know it yet. the N of each month was between 40 and 60. And of each month, roughly, there were representatives from each of the surgical subspecialties that had transfused elective cases. So that's why we decided to present to you the aggregate in general, because there was no one one group that was obvious that was over-transfusing. So we just decided to open it up to the group to actually ask ourselves to critically think about each one. And then if we decide that our subgroup needs it, let's create an argument and develop a null hypothesis and test it. But now, so you guys, and I'll hand it over to Dr. Barnhard or others to describe the utilization of this when it gets launched, which is pretty soon.
Yeah, the draft of the dashboard is actually available. The link is on the handout that we provided. This is the draft sort of menu that we have currently, and the data that Jim presented is structured very similar to this. These are all elective transfusions. The service that uses the most blood is orthopedics, and after that is cardiovascular. So you can see the services are sort of listed from top to bottom, and the length of the bars is the number of units that they are transfused. And right now, as Jim said, we're trying to develop the analytics behind it to be able to drill down by service and the hemoglobin pre and post transfusion hemoglobin levels for various transfusions and various services.
And on the, so the two other questions I had related to that were, one, do we have an idea of how much we actually exsanguinate patients in the ICU? You had a lot of data about blood transfusion that's in the ICU. It's a big issue, obviously, in pediatrics. I'm also pleased to see you dividing that, because as you know, the ability to respond to cardiac output and things are different in the pediatric population. But so how much are we exsanguinating our patients in the ICU who then get subsequent transfusions? And have we looked at that?
Hasn't been looked at here at UC Davis. It's excellent. It's something that we will need to look at in the next year.
It definitely looked like the data that you presented. The longer you were in the ICU, the more.
Yeah, the data definitely supports that, and we accept that already. Critically ill patients are routinely exsanguinated. We just haven't brought those numbers home locally to see if that's an area we can also improve.
Great work.
Dr. Cook.
Yeah, great work, great, wonderful presentation. One minor thing, to help us, or at least help our division, I would probably extract thoracic from cardiovascular, because obviously the pathophysiology of these processes is different. I suspect on the thoracic side we do quite well on intraoperative transfusion, and then we have room for improvement on postoperative and critical care transfusion. So it would help us kind of look at those graphs and determine how to do quality improvement.
Thank you. That's excellent feedback. And for others, anybody who has suggestions about how to better refine this, we're still in the midst of building it, so that's fantastic, and we appreciate that. And anybody else, you can email us. We do, and we want to reiterate, we accept the fact that people need higher hemoglobins. We all will do it. We all will see a patient and believe that they need a unit of blood. We're just working on now on following it and counting it and actually trying to be scientific about why and did it benefit them and did it not. So that's our goal moving forward. Other questions? Dr. Galante?
Well, that was a fantastic presentation and overview. One thing I want to emphasize in that one question, I would add to your slide that while transfused units of blood might not be good, crystalloid is bad and albumin is worse. Certainly in the trauma patient population, I've done a lot of effort to make sure our patients are coming out with low crystalloid being infused and 1-to-1 ratio for blood for our trauma patients. So if we can just re-emphasize that.
Yeah, and it's important, it's really critical. I'm going to interrupt Mr. Secco because this is elective patients, not the trauma transfusion literature. We do need to look at that separately. Absolutely agree. Pushback, I trained in an era where carotid artery patients and arteries got CC for CC blood, even if they started with a hematocrit of 45 or 50. And this is at world famous places. So, and in the era with a 1 in 100 HIV risk. And we did CC for CC. So I think that's too high, but I agree. This is not trauma. We need to look at that separately.
That's one of the biggest reasons we looked at elective is because with enhanced recovery, we're trying to minimize crystalloid as well.
So the other point is packed red blood cells is a component. So do you have any data for how the institution of whole blood is going to have any impact on this?
None.
We need a study.
Yeah.
Davis, do it.
So in Burns, we've done the randomized prospective trial. We have a protocol in place. Yet if you look at our graph, and you can see we're up there. Given the number of patients we have, we've transfused quite a bit.
Yeah, but still, but Burns is the best. If you look at this graph.
We're proud of Burns.
Yeah, Burns does better than any other institute.
For different points.
Yeah.
So we have the protocol, and we have evidence-based. But yet, when we come out of the OR, that first hemoglobin is still higher.
Yeah.
That suggests that the technique we are using to monitor intraoperatively is a
Right.
problem.
We agree.
Right.
So how can we address that? Because point-of-care testing in the operating room is not particularly accurate.
We agree.
We offer low albumin levels. And how can we get a better way to monitor in the operating room?
It's an excellent question, and just to reiterate it, there are differences in measurement of hemoglobin and hematocrit for those who are unaware. When you send a lavender top tube to the lab, it's spun down, the red blood cells are lysed, it's met with a spectrophotometric agent, and it's measured. The actual red cells are physically measured. When you send a lab here intraoperatively with the point-of-care technology we have here, the blood is put across two electric conduits, and the conductivity of the blood is measured. The hemoglobin is extrapolated from the conductance of the sample, which has different variability. So understand that the two different forms of measurement will be different, and they are different here at UC Davis. It's actually something that Nam Tran and Sarah Barnhard in the transfusion department and in the lab department have articulated very clearly. It's something that I'm not sure if we're all aware of.
Yeah, this is the correlation data between the central laboratory and the device that we use in the operating room, the EPOC devices. And then this is the one that we hope to bring in next year as our goal. Dr. Tran is in the back of the room, and I don't know if he has any comments to this.
Yeah, so we're actively working on moving towards this device. The main mechanism for the falsely lower hemoglobin is the hemodilution effect. So you have less protein, it's actually measuring less of the hematocrit, which is then back calculates the hemoglobin. But another component is the inadequate mixing of the sample. So this instrument also automatically mixes the specimen too. So it eliminates that user error, or at least user precision on making sure the samples of high quality. So we're actively looking at this, and we're looking at deployment in 2019.
Importantly, if we go back just to one slide there, our group, and Dr. Fleming's here too, we've looked at the non-invasive hemoglobin oximetric approach. This is worse than the non-invasive, and we think the non-invasive oximetric isn't good enough. So that's I think you need to put this in the, you could be plus or minus 2 grams of what the real number is. So a change from 12 to 8 may just be the analyzer, may not have been the patient. So transfuse the patient.
So something we can do today is apply this to our elective stable surgery patients. If we're wondering what the CBC is, then us in the Department of Anesthesiology may be more prone to send a CBC to the lab rather than run a point of care in a stable, non-urgent patient. With that said, when you have a hemorrhaging patient, you cannot wait for them to go to the lab. We have to use point of care until they're done bleeding. Does that make sense? Yeah. So we should be more mindful of when we use the point of care versus when we just send a lavender tube to the lab and wait for 20 minutes. Does that make sense? In our elective surgery patients, that alone might, interestingly enough, reduce our transfusions in that population. For urgent and emergent, we're still working on that. We're still trying to optimize the stuff that we have that's more precise than we have now. We're actively working on that. Dr. Wizard?
So I'm putting myself in the position of a new trainee who's sitting in this room. And this was really a great exposition of all the science and studies. But I suspect some of them, at least, are asking themselves, like I am, okay, what should I do? Maybe it's an unfair question, but are there a couple of takeaways, just simple takeaways, for the intern in the middle of the night who's faced with the hemoglobin, do's and don'ts? Just maybe you can oversimplify it. But.
I think that's a great question, and if I may recommend we all come up with one of our own points. My first point for a trainee or somebody in the operating room is unsure what to do, talk to your team, your upper level you're attending, and talk to the surgeon. So there's no right answer, but shared decision making is much better than an individual being forced to make that decision in something that is clearly uncertain. Clearly, there's data on both sides of the coin, but also incredibly important. Does that make sense? So when there's no clear guidance, get used to talking to people. This is not an innocuous treatment, so we should be talking to the surgeons and we should be talking to your upper levels about what the right answer to do is.
I like the idea of each adding a point. I would say, Dave, that I would say the following. A hemodynamically stable patient does not need to be transfused if their hemoglobin is between 7 and 8. They just simply don't need to be transfused. That would be the single take-home message. Now, an unstable patient, tachycardic, actively bleeding, that's a different story. But just because you come by a number and see in the ICU, in the OR, in any place, this got a hemoglobin of 7.5, that does not mean they need a blood transfusion. And the other take-home message I would say is giving 1 unit is okay. You don't have to give 2 units all the time. Those would be my 2 take-home messages.
And speaking from the position of the laboratory, don't trust the lab test. I hate to say that. I hate to openly say that, but there are so many variables that come into play when you're drawing a blood sample from a patient. And I encourage all of you to look at the laboratory test and then look at your patient and see if it makes sense. There could have been a specimen mix-up, there could have been a hemodilute sample, there could have been some error in the laboratory. There's all kinds of different things that can happen. So make sure that you're comparing the clinical picture with the numbers that we are generating every day for you.
Maybe I could just interject with the question, or maybe what I would turn that into is if you get a lab value that doesn't really make sense to you, especially hemoglobin or hematocrit, do it again, assuming you have time.
And I think that's, to paraphrase, the number needs to fit the patient. If it doesn't, in other words, you need to know why. Does that hemoglobin of 6.5 or 7, you have an explanation. Does it fit the rest of the clinical picture? Are they hypotensive tachycardic? Did you just run in a liter of fluid? And we've done that in volunteer studies. You can make a hemoglobin drop by 2 grams if you give the fluid fast enough. Does it fit? And if it doesn't, I would say even at 6, if they are stable and at 6 and everything else looks perfect, you have time to think. Redraw it, whatever it takes. So treat the patient, not the number.
And importantly, because our post-surgical patients do hemorrhage,
Yes.
and that hemorrhage clinically presents well before the lab will tell you.
Yes.
So we're not writing it off. We're not saying it's something you can just write off as an error. You have to be at that patient's bedside. You have to physically draw your own sample. It may have been drawn off an IV, or it could actually be real. You have to treat that until you prove that it is an anomaly. You have to treat that like it's real. But that treatment doesn't necessarily mean a reflex ordering of red blood cells. It means critically evaluating your patient, figuring out, is it real or is it not real? Does that make sense?
Yeah.
All right. I think that there was a question over here, and then Ken, and then Beck.
There's one in the corner there.
Who's in the corner? Oh, Lauren.
Good question for Dr. Tran.
So the question was, if a lab is dramatically different from the last hemoglobin, is there any reflex in the lab to re-trigger a remeasurement or request a new sample?
So chemistry, I cover chemistry and point of care, but chemistry, obviously, the delta checks for certain parameters such as, say, potassium and so forth. We will rerun it to make sure if there's any other issues that may be going, at least notify the provider. For hematology, I have to ask, but I don't think that there is too much of a large delta check. I mean, if there's something drastic that goes from a 10 to a 6 and within a short period of time, they will probably question that. But that's one of the key challenges, because some of these parameters do change in real time that quickly. So we can't necessarily keep calling or provide, that notification for every result. Because, for example, we have about 15,000 tests per day. So we can't necessarily call on practice.
The precision of the lab machines are fairly precise. They are variable, but they're variable within a tight range. What we suspect, and we don't know yet, is a lot of the variability that we get from the spurious results is how they were drawn.
So it's pre-analytic.
It's pre-analytic. That's what we suspect is the greater factor. So yeah, it's important to rerun, but the precision of these machines in labs has been checked and rechecked. We really want to question whether the sample we sent was adequate. Ken, and then Christian and Hong.
Okay, so one of the things that you brought up today is the fact that you can't figure out what the heck we're thinking.
Right.
Okay. So where do you want us to document it?
Right now, we're stuck with quick notes in the anesthesia record. I would love to have a pop-up dialogue that when you document that you gave blood, that
What we're doing is as we're looking at the cases, we're looking for any reaction. We're looking in the post-operative note. We're looking in the first post-op check. We're looking in anywhere in the anesthesia record. So as we figure out a better way or develop a better way, put it anywhere. Because we're scrutinizing, we're looking at the index cases, and we're trying to figure out more. As we move forward, we'll give you a better answer to that question. So Dr. Halabi, and then Christian, and then, yeah.
So we all know that blood transfusions are dose dependent. The more you transfuse, the worse the outcome. So has anyone looked at like transfusing less than a unit of blood, like let's say like in the pediatric surgery, they do CC per treatment. So can that be extrapolated from and let's say transfuse like have like half a unit max instead of like 1 whole unit, 300 ml, and then recheck the response after like transfusing half a unit?
Nobody's looked at it in the adult population, mostly because it's logistically infeasible.
But
it's a good thought.
If you look at the data that Dr. Jurkovich presented, the suspicion is that more exposures is worse for you, different antigen loads. You're getting exposed to a lot more foreign material when you get more and more units, because it's rare that it's all from the same donor, right? So probably, but I don't think anybody has that science.
Christian?
Yeah, I think the worst part about all of this hemoglobin thing is that the way that the nurses are checking the drip is from the drip arm out of the IV that they're running crystalloid into. And that's a notoriously uninterpretable sample. In no other hospital that I've ever worked at, do people collect blood like that and then act on it. And it's not the same as an A-line, because with an A-line you're only running 3 mils an hour through there in order to keep it flushed. And I keep on seeing this where they draw an diluted grits and then the surgeon orders 2 mils of blood for them in the vacuum, and we really need to get rid of that. I think, drawing a sample from an actively running crystalloid IV line is just uninterpretable.
So you bring up an excellent point, and that's one of the things we're going to roll out this year in terms of our educational is a lot of us as practitioners, when we do recheck, we have to draw ourselves, and intraoperatively we are drawing ourselves, is we'll roll out get better educational materials about the best practices about how to draw a sample. That's an excellent point. We really appreciate all of this active discussion. So a large number of us have to go and begin our clinical duties, but we're really hoping that this is just the beginning of more active discussion. There's a Transfusion Wisely group that meets every month. Everybody's willing and able to interact with us over email, in the OR, post-operatively, or even come up to the meeting with any ideas. We're asking you guys to talk about it now, come up with thoughts and ideas, and we will all work together to continue to deliver the best care we can to our patients. Thank you very much.
Dr. Lou does have one last thought for us. The poor guy.
We regularly talk about all the measurement, how the hemoglobin responds to the patient.
Right.
So I don't know how relevant those measurements are, but however, we should focus on the highest population patients, and we can better monitor. We have to monitor the organ perfusion. That's the most important, because if we can measure the organ perfusion, organ oxygenation, and even with lower hemoglobin mandatory. However, your cerebral oxygenation is maintained as normal. There's no point of doing it.
Yeah, I think you're exactly right.
Instead of doing those, pivotal restrictions, we should personalize it and make sure we have these patients cerebral oxygenation, pediatrics, kidneys, or vital organs, oxygenations, and we can use somatic. We can distinguish whether those measures can be provided as oxygen delivery, oxygen carrying capacity versus these end organ, issues. So there's I don't know for every patient. However, we do have to monitor if we can use in the highest patient population, like if we can do better care than whatever restricted and the world.
Okay.
Yeah, thanks.
All right, thank you all.
Thanks, guys.
Thank you, Rachel.